It is time for another Puscast, this one covering the first 15 days of August in the year 2015. References are available over at edgydoc.com, where you will find links to my growing multimedia empire. And it has grown again this month. I now have a Twitter account called ID Factoid, where every day I will put out 1 or 2 or 3 or 4 factoids about infectious disease. Some of them may indeed show up in your boards, and all of them will make you a better healthcare provider for knowing them. But you're more interested in the literature, aren't you? So let's move on to what I think is going to be a short Puscast this week, because it's a call weekend. I'm tired. We're going out later, and I'm going to do a half-assed job on this. Not whole-assed, but half-assed. Who'd have thunk it, but there is a review of the impact of spaceflight on bacterial virulence and antibiotic susceptibility, which is very entertaining reading if you like that sort of thing. It turns out that the space station is disgusting. It has all sorts of bacteria floating in and around it, and the condensation that occurs in the space station is a hospitable environment for all sorts of bacteria, including Legionella, Staph, Pseudomonas, and other organisms. And it is an enclosed environment, so somehow that doesn't surprise you. The most common organisms found in the air are Staph, Bacillus, and Micrococcus. The other interesting thing is that while microgravity may make organisms less virulent in animal models, the organisms also may grow with a thickened and abnormal cell wall that increases its MICs to various antibiotics such as vancomycin in the case of staph. This may not be a big deal if you're in Earth orbit, but if you're on your way to Mars and you develop an infection, it would be a bummer if your organism was more resistant to antibiotics because of microgravity. It's an entertaining read about the problems you get in spaceflight with bacteria, both in terms of contamination of the environment as well as the effects of microgravity on the virulence and antibiotic susceptibility of organisms. And who knows what will happen to bacteria at warp speed. There was an article a while back, I believe in JAMA, that showed that patients who were in isolation rooms had more complications than patients who were not in isolation rooms, in large part because they were ignored, and it's a pain in the butt to put on the gloves and gowns to go see them. This, fortunately, is not true in the ICU. This study looked at universal glove and gown use on adverse events in an ICU and found that there weren't any. So fortunately, at least in the ICU setting, putting on your gowns and gloves does not lead to increased problems. However, the difference between the ICU and the wards is that there's a lot fewer patients per nurse than on the wards, so it's not universally applicable to the hospital. And interestingly, they had fewer infectious disease complications in the ICU. Often gloves are a nice reminder to wash your damn hands, although the decrease in infections was not statistically significant. I would like to take this opportunity to be a primary investigator on any study that wanted to use universal gown and gloves on the space station. I would love to go up and see if that affected infection rates. I had suspected that part of what led to the high mortality rate in West Africa from Ebola had to do with the infrastructure, and this is somewhat supported by a study that looked at clinical features of Ebola patients in Sierra Leone. Survivors were younger, which always happens, and they sought care faster. The survivors usually showed up at 4.5 days versus non-survivor, which was 6.3 days. That's pretty impressive duration between onset of symptoms and seeking medical care for a disease that needs a lot of biomedical support. I still suspect that if you get your hands on someone very early in the course of their disease, that mortality rates will be nothing compared to what they were in West Africa. Interestingly, 18% of those presenting did not have fevers, which is an ongoing issue in screening people from Ebola endemic areas. And one does have to wonder the long-term morbidity that was described last week in the New England Journal from Ebola, how much of that would be ameliorated in more modern medical institutions. Still, Ebola is starting to fade away in West Africa, and now we can worry about important things in the United States like shark attacks and Donald Trump. Man, we have to worry about Donald Trump. I'm sure glad that climate change is a myth facilitated by the man to do something. I can never remember with these various and sundry conspiracy theories. It's been hot and it's been humid here in Portland. Normally I would just quote Mark Twain, noting that everybody complains about the weather, but nobody does anything about it. Interestingly, though, humidity is associated with the spread of infection. In the wintertime, decreased humidity might be associated with the spread of some viral infections. Increased humidity is associated with the spread of Legionella. And now it looks like a study out of Peru, where they use satellite data to measure temperature and humidity, found that dengue transmission was maximal in hot, humid weather, just what we've had in the Pacific Northwest. Now, I do need to go up to the space station to confirm this data. If you notice a theme in today's podcast. But still, if you look at projections of the spread of dengue with global warming, it may go as far north as Montreal, and it certainly has been getting more humid around here. So I think we're heading for prime dengue transmission here in the Great Pacific Northwest, if not the rest of the United States with global warming, at least for a while until everything turns into a desert. I just read The Water Knife by Paulo, last name unpronounceable. I wonder how much that predicts our future. Sigh. The one thing I always want to know in infectious diseases is why? Why? Is it luck? Blind, stupid, simple, doodah, clueless luck? That's a quote from Two-Face in Batman, for those of you who didn't know. Or is it evolution? And this is just one of these curiosities. They compared the MERS-CoV coronavirus to the wild-type bat virus and found that there were two mutations that occurred in the spike proteins that allowed the virus to infect human cells, in part by allowing the virus to be activated by human as opposed to bat proteases. That is cool. And one of the things you always worry about with bird flu, is it going to mutate in a way that will make it more infectious for humans? That also just may be a couple mutations away. So it's not blind, stupid, doodah luck. It's evolution in action. So we have a reason why MERS-CoV can infect humans now, but didn't before, because didn't have dimmed air mutations, don't you know? I'm old enough to remember when A, we did not know what caused AIDS, and B, everybody died very rapidly from the illness. I used to not care if my HIV patients smoked. Let them have the pleasure, because they were going to die of something awful soon enough anyway. Now it's critical to get HIV patients to stop smoking, not only because they get cancer sooner and more widespread, but having HIV alone is associated with progression of atherosclerosis, as this article in CID demonstrated, and it's one of many that shows that just having HIV, even with a suppressed viral load, increases your risk of progressive atherosclerosis. But it's still the smoking that is the problem. If you are smoking HIV patients, if you are an HIV patient who is smoking, that is your big risk factor for developing a cardiovascular disease. Although there is a suggestion that smoking and HIV increases your risk for stroke, it's still the smoking, not the HIV, that is bad for you. And now that you have HIV and are going to have an almost normal life expectancy, you might as well give up the evil weed in favor of marijuana. It seems to be the thing to do these days. Just kidding about the marijuana thing. But overall, discontinuation of tobacco is very compelling in HIV patients, especially given all their comorbidities. As is often the case in medicine, those that need an intervention the most are those who it's contraindicated in or in whom it doesn't work. The study looked at the efficacy of the VZV vaccine in patients on low-dose steroids. The recommendations are you can safely give the VZV vaccine in people under 20 milligrams a day of prednisone. And they did a study to see if that was true, since prior it had been due to expert opinion. Expert, X as informer, and spurt as drip under pressure, and found that indeed they had no cases of disseminated zoster, and that all the shingles that was seen in the first 6 weeks, suggesting it was reactivation rather than the virus that was causing shingles. So it's data to support the safety of giving the VZV vaccine to people who are on 20 milligrams a day or less of prednisone. And just a reminder, it is summertime. It's the hot season. People are going to be in water. Wherever there's water, it means that upstream, an animal has pissed in it. Be on the lookout for leptospirosis. There was an outbreak in Switzerland in people who had been river surfing. Boy, that sounds like fun. I guess that's what you do when you're in a landlocked country. You go river surfing. It's sort of like mountain climbing in Minnesota. Anyway, there was an outbreak of leptospirosis in a bunch of river surfers, and they had not realized that leptospirosis was in their environment. Certainly, I live downriver from the windsurfing capital of the United States. There's something you can do that's fun. But bear in mind that people who are in fresh water are at risk for leptospirosis, and keep it in your differential. And of course, you ask everybody if they are in water of any kind, don't you? I ask everybody, do you get any hot tubs, swimming pools, saunas, lakes, or rivers? It's a standard question that every patient gets from me. So I guess I'm unlikely to be missing a case of leptospirosis. And I'm probably also unlikely to go river surfing or mountain climbing in Minnesota. I mean, seriously, you have the Alps there. Why don't you go hiking? Nope, I'm going to go river surfing. I just checked out some videos. It looks like they do it on standing waves in overflowing rivers. I gotta tell you, it looks real lame. And keep in mind, although I don't normally talk about pediatric ID, that rheumatic fever is booming in American Samoa at a point prevalence of 3.2 per 1,000 children in August of 2013. So we occasionally get people here on the West Coast from American Samoa and other Pacific protectorates. So keep in mind rheumatic fever in that population. I did my residency in Minnesota all those many years ago, Minneapolis, Hennepin County to be exact. We often had patients who went off to the Mayo to get a second opinion. I always say, hold the Mayo. It always reminds me of that joke. A guy goes into a doctor's office. The doctor says, you're crazy. He says, I want a second opinion. He says, okay, you're ugly too. Well, a patient used to go down to the Mayo to get an extensive workup, basically repeating our workup and coming up with the exact same conclusions. So much for the Mayo. But Olmsted County is a population where everybody knows what everybody else is doing, kind of like Framingham. And they look to see the effect of having mitral valve prolapse on streptococcal endocarditis. And they found that MVP, most valuable player, was a risk factor for developing streptococcal endocarditis. Now, interestingly, another similar study looking at risk did not find an increased risk for endocarditis in patients with either factor V Leiden or your prothrombin gene mutation favorite in mine, the G20210A gene mutation. Neither of these had an increased risk for endocarditis despite an increased risk of thrombophilia and clot. So not everything that leads to clot leads to infectious diseases or endocarditis in this case. However, a meta-analysis does show that if you're on aspirin before you developed endocarditis, you are likely to have a reduced risk of systemic embolism. So the factors that lead to clot on the valve, such as MVP, may increase your risk of endocarditis. Having hereditary thrombophilia maybe doesn't increase your risk of endocarditis. Keeping your clot size small with aspirin makes you less likely to have embolic events. So So there's a lot of subtleties in the risks and benefits of interventions with clot and endocarditis. And then, of course, I always yammer on about how infections are prothrombotic and lead to a variety of vascular events, but endocarditis is not on that list as a rule. And I just thought of a brilliant idea for a reality show, Olmsted County versus Framingham. They could do football, they could do races. It would be an Olympics between the two most medically analyzed populations in the United States. It would be better than Ambien. Good news, bad news. So a study out of France. So they took people who traveled to tropical countries, and they had patients send in their MERD to see if they had multi-drug resistant Enterobacteriaceae. And they found that yes, if you went to Asia, 72% had MRE in their MERD. If you went to Sub-Saharan Africa, 47.7%. And Latin America, 31.1%. So traveling abroad to tropical countries was associated with developing multi-drug resistant Enterobacteriaceae in your MERD. But the good news, it didn't last long. After 3 months, a mere 4.7% of the travelers continued to carry MRE in their MERD. So this would appear to be at least one microenvironment, the colon of a French person, that is inhospitable for multi-drug resistant organisms, and they would appear to have a selective disadvantage compared to the normal French stool population. The take-home, though, is that if a patient has traveled to a tropical area in the last 3 months, keep in mind that they could have acquired a multi-drug resistant Enterobacteriaceae to cause their urosepsis or whatever. And for those of you who are not as fluent in French as I am, and I'm not, MERD is stool. A quick note that actinomyces may be a cause of breast infections. Certainly, I've seen a fair number of patients over the years with chronic drainage from breast infections, and they suggest in this study that actinomyces are often there and often not identified because A, people don't look, and B, they're difficult to grow. So keep in mind actinomyces with chronic recurrent breast infections. I often get called from orthopedics about bacteria in the urine just prior to elective hip replacement. And patients who have bacteria in their urine have a slightly increased risk of hip infections, but it's not due to the organism in the urine. So it's more a marker of debility than it is of causality. A similar study looked at the risk for hip infection in patients having GU procedures and whether antibiotic prophylaxis did anything. The answer is no. Genital urinary procedures are not risk factors for prosthetic joint infections, and antibiotic prophylaxis did not decrease the risk of a subsequent hip infection. So if you have to do a GU procedure on a patient, don't worry about the knee and don't worry about the hip. It ain't going to get infected. Not that anyone's ever going to believe it. I still have patients receiving dental prophylaxis for their knee and hip. One, in fact, got a joint infection a couple of weeks after their dental procedures, and everyone wants to blame the dental procedure. I don't think so. I seem to be seeing more spine infections as my career progresses. I don't know, maybe that's not true. The only people I know who are resistant to spine infections are presidential candidates. You see, they're spineless. Anyway, one of the standard consulting questions is how long to treat. And this study randomized patients with vertebral osteomyelitis due to bacteria to either 6 weeks or 12 weeks and found no difference. The only caveat in the study is they had a relative paucity of MRSA. Only 8 of the 145 patients had that infection. The majority were either MSSA or coagulase-negative staphylococci. So these were post-operative infections for the large amount. There was a study that suggested that 8 weeks was better than 6 for MRSA vertebral osteomyelitis. It was a retrospective study, not a prospective randomized study. I still would be hesitant to give MRSA a mere 6 weeks, and I'm always inclined to at least give a long-term follow-up of oral therapy in that population. These are also interesting studies often in that patients are rapidly changed over to oral therapy, often after 2 weeks or so of IV. I've always been very hesitant to treat spinal osteo with oral therapy, in part because if you fail, it's a difficult bone to debride. You can always remove a leg or an arm if you have to, but outside of Mortal Kombat, it's difficult to remove a spine. Sometimes you have to look at a study and ask, is this the optimal therapy or is this what you can get away with? I'm still going to stick with overkill when I treat my spine infections. I will be sub-zero for treating spine infections. So I have this habit with prosthetic joint infections that when we get a washout and poly exchange and it's a staph, I've tended to put them on chronic suppressive therapy at the end of their IV. Figuring that the only way to prove the staph is gone is to stop and see if it comes back, in which case we're back to square one. And patients don't usually want to do that. This study actually addressed the issue as to whether or not this is a benefit. And they found that those who had a poly exchange or those who had an MRSA infection benefited from long-term suppression and kept their joint longer than those in whom antibiotics were stopped. The minimum duration of oral antibiotics was 6 months in these patients. I've had patients now on several years' worth, and they, like me, are afraid to stop the antibiotics because if the staph come back, they're up creek without paddle. But it is nice to have a study that at least somewhat validates my practice. We have this medical theater, at least I think it's medical theater. I need to write an essay on medical theater, where we are assigned patients from Ebola endemic areas in case they have a problem, although none of them have risks for Ebola. And when they've had fevers, no one's worked them up for Ebola. They've had other problems. But what are those problems? This study looked at the diagnoses of people coming from West Africa, and they found that most of them had the usual stuff: malaria, diarrhea, URI, UTI, and influenza-like illnesses. There was a smattering of typhoid, HIV, and dengue, but nobody had Ebola. Following these travels as part of Ebola screening is medical theater, being done in large part to make people not involved with patient care feel like they're doing something of benefit, when in fact they're not. They're just making the lives of clinicians that much more complicated. If Ebola does come, it will be a disaster for the person having it, for the hospital taking care of the patient. But still, the statistical likelihood is so tiny, especially here in Portland. There's an article, a review on oritavancin, a drug I have only used once, and only then because of psychosocial issues. It's the only way I could get a drug into a patient was every 5 days. And it ultimately failed in treating the patient's infection. They relapsed. But what really fried my bacon was the cost. As they say in the review, quote, the acquisition cost, $2,900, of this antibiotic may ultimately limit its use. You think $2,900 for a 5-day course of antibiotics? I mean, that's a fully loaded MacBook Pro, high end. And that's my metric for determining drug costs. How many fully loaded MacBook Pros could I buy? With oritavancin, 1. That's crazy. Take a mediocre drug with a long half-life and overcharge for it. That's a good way to market it. Okay, 24 minutes and change, and we're done. I'm going to bring this to a close because A, I'm tired, B, I've run out of things to say, C, we're going to a concert tonight, and D, I have to get my walk in. There's more to life than doing podcasts, believe it or not. This has been a Puscast covering the first 2 weeks of August 2015. References are available over at edgydoc.com. And of course, There you can find links to my growing multimedia empire of blogs and books and podcasts, and now ID Factoid, a Twitter feed just for you. Otherwise, see you next time, and as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.